Hi, this is Sean Haverson with C&M. In this module, we're going to go over waveform capnography for the C&M EMS refresher. The goal that we have is to understand the physiologic process that we're measuring within our patients using capnography and be able to apply this to our patient care. Our objectives include identification and compare and contrast of things like ventilation, respiration, and metabolism, understand capnography, normal values, and abnormal findings, as well as what those abnormal findings means for our physiologic and pathologic processes in the body. At the end, we'll explore a few patient conditions, we'll give you some capnography information, and identify appropriate therapy. Starting with the basics of capnography, we're measuring with capnography exhaled carbon dioxide. When we measure the exhaled carbon dioxide, we can represent that in a waveform known as capnography, or with just a number, capnometry, or a combination of both. Carbon dioxide that we're measuring is the byproduct of metabolism, and the route that it makes through the human body as it exits the body is going to give us an insight into the patient's condition. Looking at metabolism, we can think back and zoom in to the level of the cell. As you recall, the cell has a powerhouse within it that is going to take some basic components and create energy with it, and that's the mitochondria. As it was explained to you at some point, it was probably referred in comparison to a factory. Well, let's use that analogy now. What we're going to use is oxygen and glucose combined through the mitochondria in the process of metabolism. This efficient process is going to output adenosine triphosphate as our energy and a byproduct of waste, CO2. Carbon dioxide levels and waste will increase as we have a decrease in the efficiency if we lose either oxygen or glucose in the process of making energy. If we zoom back a bit and now look at the body as a whole, we can identify that the process of measuring end-tidal CO2 is actually measuring in a passive way other processes. Metabolism, internal respiration, so the process of moving gases out of cells through interstitial space and into the capillaries, perfusion and cardiac output as we move the gases through the body, external respiration as the gases offload from the capillaries into the alveoli, and then finally ventilation as we move mechanically the gases out of the lungs and to our measuring device. Respiration, as a term, is the process of things moving across a barrier, generally gases, with the basis of diffusion. Diffusion, as you recall, is the process of moving things from areas of higher concentration to lower concentration. This is important because it doesn't expend much energy in order to get the work done, an efficient model for the human body. Respiration can occur internally and externally, and also at the cellular level. Cellular respiration is movement of gases in and out of cells. Respiration occurring internally is the movement through the interstitial space and into capillaries. And external respiration, finally, is the movement of gases from the capillary and into the alveoli and vice versa. In the diagram here, we see that our CO2, carbon dioxide value, within the blood flow is 45 millimeters of mercury at this measured point. The blue area, the blue circle rather, is indicating the inside of the alveoli. If our CO2 is 45 millimeters of mercury within the capillary, the CO2 within the alveolar structure is generally going to be 2 to 5 millimeters of mercury less. That allows for diffusion to occur and moving from an area of higher concentration to lower concentration. What we're measuring when we measure end-tidal CO2 is very closely associated with the value in the blood. Measuring devices of CO2 can involve semi-quantitative capnometry, quantitative capnometry, and waveform capnography. Although probably not well known by its name, semi-quantitative capnometry is well known in the EasyCap style detector. As we're looking at this here, we see that there's no millimeters of mercury measured on this because we're actually measuring pH on a litmus type paper. Semi-quantitative capnometry is going to give a pH measurement in the condensation of water exhaled out of the body. This is best used for initial tube conformation, and the pH sensitive paper is going to change generally from an area of purple color to brown to yellow. And yellow means that yes, generally, this tube has been placed in the trachea. There are some significant pros to using this device. It's quick to use, doesn't require much training. There's no batteries or technology associated with it. It's inexpensive, and it's compact enough to just keep in your airway kit for quick use. Downsides associated with using this is that it's only usable once, and once you put it onto the tube and give a few breaths and the pH causes the paper to change color, you can't use it again to look at the maintenance of your tube. It will not change color if your tube is dislodged. Other things like vomit, secretions, and blood, when they come in contact with this paper, can cause it to change color, unfortunately. If the tube is placed into the esophagus and there's vomit that comes up the tube, it'll probably give a false reading. There's no number or waveform that we can utilize on this. It's a yes or no proposition. The next step up is quantitative capnometry. This is going to measure CO2 in a numeric value. It's attached to the tube, and the normal range that we'll be evaluating for end-tidal CO2 on all measuring devices for the human being is 35 to 45 millimeters of mercury. The device pictured here will also give us a ventilatory rate as well as that end-tidal CO2 value. The next step, qualitative capnography, is going to utilize a waveform, which we can see as the bottom waveform on the LifePak 15 pictured here. It's also going to give a metric number or a value within that range or outside of that range that we discussed on the previous measuring device. This type of technology is integrated into most modern advanced life support monitors. It can also be a standalone monitor for use not associated with things like the LifePak, Philips, and Zoll monitors. Another benefit to using this is that you can trend over time patients that are intubated and patients that are breathing under their own power by using a modified nasal cannula, which is pictured here. The term end-tidal CO2 is the measurement of the CO2 and carbon dioxide value at the end of the exhaled tidal volume that's within the lungs. As the patient exhales, a waveform is produced. If we're looking at the printout from a normal EKG monitor, using the graph paper as shown here, we can identify the components of the waveform. To begin, our graph is going to have an x-axis value associated with time, just as an EKG would. The y-axis of the graph is going to be associated with the CO2 concentration. A normal waveform will look something like this. Notice that this has a square shape with a plateau at the very top region of the wave. We can go through each component to tell you what's going on, and in the next slide we'll compare this to the anatomy of the body. The first area turning green here is our baseline, and this is the area present in between ventilations, specifically when inhalation is occurring before exhalation is going to occur. The first positive portion of the waveform is our first measurement of CO2 as the patient begins to exhale, and this is a measurement of the gases that are in the airway. As we get closer to the plateau, noted as the alveolar plateau, we start to measure the concentration of end-tidal CO2 that was within the alveoli. The downward portion of the wave is telling us that the patient is now breathing inward, inhaling, and drawing the CO2 gases back into their airway as they take a deep breath. And we'll finally return to baseline before we start another ventilation. Taking our waveform now and looking at the structure of the lungs, we can identify exactly where the CO2 on our waveform is coordinating with the section of the airway. The green arrow is associated with the dead space in the larger airways. As we see the rise of CO2, the first portion of CO2 as the patient exhaled to our monitoring device is going to be from the closest areas to the monitoring device. As the movement of the wave goes upward, we're starting to measure both the dead space, and as we come closer to the plateau, we're measuring a mix of dead space gases, larger airways, and the beginning of the alveolar gases. The plateau is going to measure the hold of end-tidal CO2 values that have CO2 directly from the alveoli. What's important about that is this plateau is giving us a real-time reading of the CO2 that was offloaded from the capillaries just before the patient exhaled. The point at the end of the plateau, just before the wave goes back down towards baseline, is associated with our final end-tidal CO2 reading for that ventilation. As we move closer to baseline, the patient has now drawn air and gases back into their lungs and taken the measurement gas away from our measuring device and into the lungs as they oxygenate. Putting these things together, we can look at the ranges outside of our normal values. Hypercarbia and hypocarbia are related to larger and smaller values of CO2 than our normal range. Hypercarbia is going to show on a normal waveform pattern as a taller waveform as our value of end-tidal CO2 has grown over 45 millimeters of mercury. Since we have more gas present that is associated with acids within the blood, our patient might be acidotic at this point. Hypocarbia is the opposite of that. Patients with hypocarbia are likely alkalotic in their blood chemistry. Their waveform, if it's normal in shape, is going to be shorter, and the end-tidal CO2 value will be below 35 millimeters of mercury. Causes for high and low values are listed on this screen here. For hypercarbia, respiratory depression is a common culprit. Respiratory depression means that your patient is breathing less frequently, but they're still creating the CO2 in the body. Since they're still creating the CO2, but we're not blowing it off at the rate that we would expect, the CO2 is retained and their CO2 value will be higher. Incidents of higher cardiac output or higher metabolic rates are also associated with hypercarbia. Fever, sepsis, pain, and hyperthermia are all going to relate to higher metabolic rates, assuming that perfusion is good will lead to a higher end-tidal CO2 than we would expect. Slow ventilations provided by a ventilator or a person using a BVM are equivalent to respiratory depression. If we're breathing for a patient who can't breathe on their own, but is still creating the gas through metabolism, but we're not breathing enough to blow off that CO2, we're forcing the patient then to retain, and we could be changing their blood chemistry. Hypocarbia is associated primarily with states of either low metabolic rate or low cardiac output. Pulmonary embolism is a blockage of this, and although we may have good cardiac output, we might not be getting the CO2 gases to portions of alveoli because of the blockage that can be offloaded through ventilation. Pulmonary edema may have good cardiac output at some portion of the cardiac cycle. However, because the blood is in the circuit, the gas is not easily transferring from the capillaries into the alveoli. Hyperventilation from a normal state will blow off more CO2 than is expected, leading the patient to a low CO2 value. Decreased cardiac output, hypothermia, cardiac arrest, and shock generally will produce hypocarbia as well. Hyperventilation is outlined here as an abnormal waveform for us. Hyperventilation, if in the presence of a normal patient with neither an increased or decreased metabolic rate, can be a problem. If we look at this waveform, we can first identify that it has a normal structure. Each waveform is square and has an alveolar plateau. But we're seeing over time there are more frequent ventilations, and more frequent ventilations mean that we're blowing off carbon dioxide more frequently and bringing down our carbic level. We see that we start off at the first waveform with a end-tidal CO2 near 40, and at the end we're nearing 20. Hypoventilation, as its opposite, again, all things being equal, creating CO2 at a normal rate within the body. If the patient's breathing less frequently over time, they're not blowing off that gas and will start to retain carbon dioxide. As the patient becomes hypercapnic or carbic, the patient's value is seen here going from 40 upwards of 50 or closer to 60. Another abnormal waveform is a loss of plateau. The loss of plateau can be seen here with the absence of the square waveform and really no plateau associated with alveolar emptying. The shark fin appearance is indicative of some airway obstruction. COPD and asthma can show this as bronchial constriction occurs. Also, secretions and blockage within the tube are making it harder for this patient to offload the gases, and it's shown in a slurred measurement. Here we see apnea and arrest and tube displacement in the presence of a loss of waveform. If we're measuring a waveform and we see good normal square with plateau waves, and then suddenly they just completely are absent, then we probably have a patient who has stopped breathing, is in cardiac arrest, or our tube has been displaced from the trachea or its normal position. At the bottom, we're seeing no square waveform, just a hump appearance that's decreasing over time. The bottom waveform is likely associated with an esophageal placement of a tube. Remember that there are going to be releases of CO2 in the stomach, but there's no association with an exhalation through anatomical structures that we can equivalent to our square waveform, and we see just variable waves associated with some CO2 presence. In a patient that has a normal waveform, or at least a waveform of some kind that is thought to be within the trachea, and we see a loss, we immediately need to start troubleshooting. Just like any condition in our patients that's changed, especially critical patients, we need to start back with our ABCs. The first thing to check is this patient breathing? If we were breathing for them and suddenly we have a loss of waveform, we need to make sure that our BVM is still compliant and somebody's squeezing the bag, or our ventilator is still connected, powered on, and cycling. Does the patient have a pulse, which would indicate cardiac arrest? And also checking the tube. Was it displaced? Do we have a kink or a block within the airway circuit? Or did our end-tidal CO2 measuring device fall off? Capnography is considered a gold standard in monitoring tube placement initially and also in measuring the maintenance over time. It can give us a real-time feedback of ventilation adequacy, whether we're using a BVM, our patient's ventilating on their own, or we have a ventilator attached. An interesting finding in capnography is that when measuring it and trending it over time, providers have found changes in a patient's condition before outward signs and symptoms have manifest. There are some limitations using capnography. Please understand that in a patient that has a low cardiac output, like shock, we're going to have low false readings. Although they're creating perhaps even more acid and more CO2 from inefficient processes and a lack of oxygen, our patients are going to exhibit low values because the blood is not getting that gas to the lungs. That by itself is a problem for our patients and warrants a change. Airway pressures, although we may have good cardiac output, an increase in positive end expiratory pressure is going to decrease the diffusion and perfusion that's occurring around the alveoli. This would still show a low false reading. Also, take into account that good waveforms do not necessarily indicate good oxygenation in our patients. End-tidal CO2 is important in the use of measuring and monitoring cardiac arrest resuscitation. It'll be initially used in the confirmation of tube placement. But additionally, in measuring this while you're performing resuscitation, the American Heart Association ACLS 2010 recommendations include that end-tidal CO2 should be at least 10 millimeters of mercury during CPR. Anything less than 10 millimeters of mercury is showing that you should change something about your compression quality. You may need to increase the rate, the depth, or identify that your providers are becoming fatigued. Also, trending over time, which is present in the waveform at the bottom of the screen, can show that the return of spontaneous circulation has occurred well before pulses are present in our patients. An abrupt increase in end-tidal CO2 during resuscitation is an indication of return of spontaneous circulation. End-tidal CO2 is also useful in the management and monitoring of head trauma. PHTLS's 7th edition includes management of traumatic brain injuries to have a maintained end-tidal CO2 of 30 to 35 millimeters of mercury. To achieve this, you're generally going to ventilate slightly faster than normal to bring the end-tidal CO2 level down in a patient, inducing mild hypocapnia. For patients with a traumatic brain injury and signs of increased intracranial pressure, PHTLS's 7th edition recommends maintenance of end-tidal CO2 of 25 to 30 millimeters of mercury. It's important to note when using this as a gauge for your ventilation and your treatment status that patients with traumatic brain injuries very commonly in EMS present with multi-systems trauma. If multi-systems trauma includes hypovolemia, the patient's cardiac output may be decreased and our end-tidal CO2 value might be lower than it actually is. How's this work? In inducing hypocapnia by increasing ventilatory rate, hyperventilation mildly, can cause an alkalotic state in our patients. Alkalosis is known to cause cerebral vasoconstriction. This is useful and tied to more positive rates of outcome in patients with traumatic brain injury because we're decreasing the flow of fluid that's going into the cranium, spilling into the cranium and increasing the pressure within the cranial cavity. That increased pressure, as we know, is decreasing perfusion to the cells, leading to a hypoxic state. Now, there is a very fine line, and this has to be done with extreme caution. If we're using this and we create too much of an alkalotic state, we're going to cause two more negative things to happen. If we cause profound cerebral vasoconstriction, no blood and oxygen is going to get to the brain at all for the tissue that's still alive. Also, in addition to the profound vasoconstriction, alkalotic states are generally going to hold on to oxygen more tightly within the hemoglobin and not allow it to be released when it does get to cells that are requiring that oxygen. Both of these things can actually cause an increased rate of tissue death and make our patient's condition worse. In summary, we've discussed that end-tidal CO2 is useful in the measurement of metabolism, perfusion, respiration, ventilation, and blood chemistry. It can also give us feedback on our ventilatory efficiency. It's going to indicate physiologic changes earlier than we would expect to see outward signs and symptoms so that we can manage things before they become aggressively negative. Also, we've identified that normal values include a range of 35 to 45 millimeters of mercury. Our normal waveform is going to be a plateau and square in appearance. And in some cases, manipulation of our end-tidal CO2 values can improve patient outcomes. Before we finish, let's try two cases and use this to bring some of the things we've learned into application. Presently, we have a 17-year-old male at a local school who's complaining of chest pain, difficulty breathing, numbness, and cramping. The patient is noted to have been involved in a verbal argument, currently crying, but is otherwise healthy. Would you expect this patient's end-tidal CO2 value to be low or high, and why? We would expect the value to be low. The patient was likely normal capnic, and when they started to increase their ventilatory rate, they blew off CO2 faster than they needed to. New patient. We have a 30-year-old female who's experiencing a thyroid storm. She has a history of hyperthyroid and frequent dehydration. Signs present show thyroid storm with a heart rate of 149, strong and irregular. EKG is showing unifocal, non-perfusing PVCs. Lung sounds are clear, yet the ventilatory rate is increased, and our blood pressure is high. Same question for this patient's condition. Although the patient is breathing at an elevated rate, which was the same we had with our patient before, this patient's underlying state is abnormal. The patient has an increased metabolic demand, so they're creating more energy, they're using more oxygen, and creating more CO2 in the output. They also have an increased cardiac output and stress within the heart and cardiovascular system. This patient's end-tidal CO2 is likely going to be high. Thank you for your time. Here's some references that I utilized to put this together. I'm happy to share these with you if you need further information. Please progress to the quiz as you move forward in the refresher.